So the optimal frontline treatment for patients, older adults with AML, is somewhat controversial. It's well established that patients who are clearly unsuitable for intensive chemotherapy, who are 75 years of age or older, or who have significant comorbidities, should be treated with Azacitidine and Venetoclax. However, it's much more controversial in terms of what should we do for a patient between, let's say, 60 to 74, who appears to be a good candidate for intensive chemotherapy. How should we treat that patient? Should we give them intensive chemotherapy, or should we give them a lower intensity regimen with Azacitidine and Venetoclax, for example? And this is assuming the patient can subsequently undergo transplant. There was historically some hesitancy to treat patients who are transplant candidates with lower intensity regimens, with the thought that we would get deeper responses prior to transplant by treating them intensively. The challenge, though, is that if you treat an older patient with intensive chemotherapy, you have a reasonable likelihood that that patient could have a significant decline in their functional status and therefore no longer be a candidate for transplant. So this is an area of active controversy and discussion in the AML community. Now, we did an analysis just asking the question, taking only patients who went to subsequent transplant, does it matter how they got there? Does it matter what type of induction they received? So we took patients who received either intensive chemotherapy, low intensity therapy without Venetoclax, this is in the pre-Venetoclax era, or who received lower intensity therapy plus Venetoclax, all of whom subsequently underwent transplant. And what we found is that actually the outcomes are very similar regardless of whether or not they received intensive therapy or lower intensive therapy with Venetoclax prior to transplant. And in fact, the non-relapse mortality may be lower in patients who received lower intensity regimens, probably because they retained better functional status, because they weren't treated with intensive therapy prior to the transplant. So the main conclusion from this study is that it probably doesn't matter how you treat the patients in the frontline setting, either intensively or low intensity therapy. I will say, at my institution at MD Anderson, our preference is to treat all patients, essentially almost all patients, who are 60 years of age and older with lower intensity regimens, because we see very high rates of response, good MRD negativity, and we find that patients are ultimately better candidates for transplant and tolerate transplant better if they received a lower intensity regimen prior to transplant, rather than if they receive an intensive regimen where there's a very high rate of significant morbidity and also even mortality in patients, older patients, even if they appear to be fit for intensive chemotherapy. Unfortunately, we're often surprised, and patients can have significant complications.